Chiari syndrome is a veno-occlusive disorder which is commonly seen in Indian subcontinent. And we get patients with Chiari syndrome presenting in different clinical manifestations, and most commonly we see patients coming to us with a swollen abdomen and engorged vein over the anti-abdominal wall, and symptoms like non-healing ulcer with swelling of the legs. Now, this Chiari syndrome could be because of occlusion of the hepatic veins, or it could be because of occlusion of the inferior vena cava. And there are sometimes you have combination of both. So now, ideally, the Chiari syndrome's treatments are done through medical management to initially to begin with, and then subsequently, when the disease progresses, we need to do anatomical corrections, and those could be hepatic venous angioplasty and stenting, or that could be IVC angioplasty or stenting, and finally we have procedure like DIPS, that is a direct intrahepatic portosystemic shunt for treatment of Chiari syndrome. Today we are going to show you a case which is very complex in its nature. The reason being, this patient is having IVC occlusion, long segment IVC occlusion for a long time, and she is presenting to us with a non-healing ulcer of the lower leg. And we must understand one thing, that it is very difficult to open a chronically occluded IVC. So we are going to discuss a special technique that we do to treat such patients with long-standing, long segment IVC occlusion. Thank you. This is the liver, and we have three hepatic veins, the right, the middle and the left hepatic vein. They will drain into the inferior vena cava, and the inferior vena cava per se will go into the right arteriole, and that will come to the right ventricle, and this is what it is, like this. So now, if there is an occlusion of the hepatic vein, one or the many, or if there is a occlusion of the IVC, retrohepatic IVC especially, then you will land up with the Chiari syndrome. So if there is only the IVC is occluded, hepatic veins are fine, then you just do an angioplasty and stenting of the IVC, that is good enough. But if you have the hepatic venous disease, then probably you deal with the ostial stenosis, then you come inside here and do angioplasty and stenting of hepatic veins, so that is going to be good enough. But in some cases, we have all the hepatic veins, they have been occluded completely throughout the course. Then you have to come here and you have to make tips, that's into the portal vein, and you make a, so this is the splenic and this is the supramesenteric, this is the portal. So you do a stent graft from the portal vein into the IVC, that is called DIPS. So there are various methods to treat basically this Chiari syndrome when it is beyond the capacity of medical management, where you have to do an anatomical correction. So either you can do a hepatic venous stenting, or you can recanalize the IVC by angioplasty stenting, or you can do a DIPS. What we have today is very complex situation, because we have this entire retrohepatic segment is thrombosed. There is no flow going whatsoever, and there is a large coletals over here from the infrahepatic IVC, and the intrahepatic IVC is completely occluded in a long segment. So they are often very difficult to recanalize. So we are going to tell you about a special technique that we employ to recanalize such lesions. So what we do is we take a catheter and we put it as a guide over here. So this is sitting over here all the time. Now we take 11 French sheath here, and then we take about 10 French long sheath, and within that we take a bevel needle, and within that bevel needle we take a chiba. So if you just magnify and see, so this is the IVC occlusion, occluded IVC. So we have the 10 French sheath over there, and then the bevel needle over here or a septal puncture needle you can use. Then you have your Chiba over here. And then try to target the Chiba and try to meet that long sheath and the catheter that you have put here, and try to go through it and go through this occlusion all the way and try to catch this and get inside that. So we are going to demonstrate a case. How do we do that special technique, especially to recanalize those chronically occluded IVC resulting in Chiari syndrome. That's going to be interesting. So this is the IVC gram of the patient today who is suffering from Chiari syndrome with a non-healing ulcer over the legs and swollen abdomen with engorged vein over the anterior abdominal wall. Now if you look at here, the IVC gram, the IVC is occluded, we can see that, and there are a lot of collaterals over here, and ideally the IVC should join into the right atrium over here. That's not happening. So we are trying to go across the lesion through the blunt end of a termo wire, and we can see a little bit of flow, but that's not enough because it's a long segment occlusion here. So what we are trying to do now is taking a large balloon so that we are very centrally placed and trying to take the blunt end of a wire and just poke lightly whether we can manage to go in there, but that's not happening over here. So now we get into the technique for chronic IVC occlusion, which we have devised over here, and what we do is we put a long angle sheath from the jugular and try to just go as close as possible to the occluded segment of the retrohepatic IVC, and we just put a catheter. This is a marker, and now we come from below and we try to see that how we can oppose each other, and we try to go from this side and get inside the sheath, and that's what we will try to do here. And this is what I'm trying to do. I have my angle sheath over here with a wire and the catheter so that it's well protected and it's not hurting the heart. And from here I have gone with the triad of the long sheath and the septal puncture needle with the Chiba needle and a 14 wire. So these are the four things that have gone: the sheath, we can see here, the septal puncture, and the Chiba and the 14 wire all together. So the Chiba is over here, the 14 wire is over here, and the sheath is over here, and the septal puncture needle is over here. And I am trying to approach it, and I will go to the lateral so that, yes. So it's always, in my experience, it's always you just have to try to go anterior. And interestingly, our sheath is also over here, and because IVC is very posterior placed over here in the infrahepatic segment, once you are coming here, you try to go a little anterior and try to go inside the sheath with your Chiba. So that's what we are trying to do here, and I will show you how to do that. And this is our Chiba, and you're very safely placed and you're going very smoothly, and get inside, get to the lateral view. So you have not punctured, you're still in the occluded segment, you're trying to get inside the sheath, but very gently, hardly pushing about a millimeter by millimeter. And you should know where your IVC is during this procedure. So, and once we just get inside, this is inside the sheath, you can check, this is inside, my Chiba is inside the sheath. And then once my Chiba is inside the sheath, and put your 14 wire going all across over here. This 14 wire goes up into the sheath, and once you have achieved that, so I am pushing my wire all the way up. So you can see my 14 wire through the Chiba has come here, and I'm quite safe and feels great. So once that is done, then you have your 14 wire over here, and then you can push your Chiba a little bit further, and then you can do your exchange for 035 wire, and then you can finish your procedure. You can see my Chiba is going up here over the 14 wire, and then I can take my diagnostic catheter with a wire back and I can put my Chiba inside, which I am doing safely. Yes, so my Chiba has gone inside over here and the diagnostic catheter has been taken off. So now you see the sheath, you see the septal puncture needle, you see the Chiba and the 14 wire getting inside the jugular sheath. And then you have to go for a serial balloon dilatation. I have just pushed my sheath all the way in and pull everything out, keeping the sheath here, and then put a 035 stiff wire so that you can go ahead with your balloons. So this is what it is. And now my sheath is well inside the jugular sheath. My femoral sheath has gone inside the jugular sheath, and then I will push a 035 wire. That's my 035 wire going all the way. And once that is done, then of course I have taken the balloons and inflated and made the segment stable. And once the balloon angioplasty was done, it looks quite good. We can see the blood flowing into the heart. We can just take another injection closely. We can see the IVC. You see this large collaterals over here. They are going to go once we put a stent. I have chosen to take a wall stent 18x60, that's second balloon angioplasty, and then I have pushed my sheath all the way down to do a check angiogram. We can see my jugular sheath is across the occlusion and into the intrahepatic and infrahepatic segment of the IVC. And this injection demonstrates that there is a free flow of the IVC into the right atrium. That is what we wanted to achieve. Once we have achieved that, then we can put a stent. So now this is my wall stent going inside there. This is my wall stent. And then I have deployed the wall stent. You can see the wall stent getting deployed over here. So this is my wall stent starting from here to here, and then I have completely deployed my wall stent. Beautiful look. And a little bit of angioplasty I would love to do in this segment. And finally the flow is beautiful into the heart. And this is how we deal with such complex chronic IVC occlusions, long segment causing Chiari syndrome. And this is the technique that one has to do to get rid of this type of IVC occlusions. Thank you.